Yes, good afternoon, everyone. Thank you all for joining in our today's PEM lecture series. We're very happy to have you joining again this month. This is our second pediatric lecture series for this year, and we're going to be having a very interesting topic that is going to be talking about approach to pediatric arrhythmias at ED settings. And we're going to be having two presenters that are going to be taking us through today's talk. We will have Dr. Biita, who is a pediatric emergency medicine fellow at MUHAS, and Dr. Emily, who is an associate professor at University of Washington and working at Seattle Children's Hospital. So we welcome you all through our presentation, and we are sure at the end of this presentation, you're going to learn a lot. Just to remind you, this is a CPD accredited activity where all of you who have joined in today will get 3 CPDs. But please bear with us. Currently, the MCT portal has been updated, so there are some challenges in claiming CPDs. That's why even the previous PEM lecture series, we have not yet claimed your CPDs. But rest assured, make sure you've written an MCT number on the chat, and you're going to make sure that we claim your CPD once the MCT portal is working. Again, these are all recorded lecture series. If you missed any of this, you can always go back to our YouTube channel, which I've shared the link on the chat, and you can always access them at any time. Just keep on learning. Likewise, we always like to present or talk the topics that you want to hear from us. So I've also shared a link where you can tell us what topic do you wish to hear from us. So without wasting much time, I'll now like to welcome the first presenter who's going to take us through the first part. I'd like to welcome Dr. Biita.
Yes, good afternoon. Thank you, Dr. Humphrey, for giving me an opportunity to present in this forum. The topic is about pediatric arrhythmias. This presentation is going to have two parts. The first part is about introduction, causes of pediatric arrhythmia, classification of pediatric arrhythmia, and abnormal rhythm. The second part will be specific management of most common pediatric arrhythmias. The second part will be presented by pediatric emergency medicine consultant from Washington University. In this presentation, we have three objectives. One is for you to understand the approach to a pediatric patient who is presenting to the emergency department with arrhythmias, mainly to understand those who present with signs of instability and those who presented in a stable state, but also to understand the primary and the secondary causes of pediatric arrhythmias. The second objective is to review the classification and the types of pediatric arrhythmias, mainly focusing on tachyarrhythmia and bradyarrhythmias. The last objective is to summarize the treatment of the most common pediatric arrhythmia management. So what is pediatric arrhythmias? American Heart Association has defined pediatric arrhythmia as any abnormality in the rate, regularity, or site of origin of the electrical impulse in the heart. That means if a child presents with a slow heart rate, it means the child has arrhythmia. If the child presents with a fast heart rate, that means the child has arrhythmia. Also, if the interval from one beat to the other is not uniform or is not constant in all of the cardiac cycles, it means the child has arrhythmia. But also we know that in a normal child, the impulse starts on the sinoatrial node and then goes to the AV node and then to the ventricle. So if the impulse is not following this channel, then the child has arrhythmia. So what are the causes of pediatric arrhythmias? The causes are grouped into two groups. The first group is primary causes of pediatric arrhythmias. Here we mean that the arrhythmias are the cause of this pediatric arrhythmia are within the heart itself. For example, the child has a heart block or the child has a congenital anomalies which is involving the structures involved in generating and transmitting the impulse. The examples of arrhythmia which can develop because of primary causes includes supraventricular tachycardia, long QT syndrome, and heart block. The arrhythmias which occur because of the primary causes are also called primary pediatric arrhythmias. The second group of causes is secondary causes of pediatric arrhythmias. In this, we mean that the heart is normal in terms of structure and the physiological, but the problem that the heart is developing arrhythmia because of the causes which are outside the heart. Example of these secondary causes includes hypoxia, metabolic derangement like acidosis, hyperkalemia, hypoglycemia, hypocalcemia, and others. Other secondary causes include hypovolemia or hypotension, hypothermia, drug intoxication, or increased vagal tone. So these secondary causes are also called reversible causes of pediatric arrhythmias. It means they are treatable. The arrhythmias which occur because of these secondary causes are also called secondary pediatric arrhythmias. So, why are we worried about pediatric arrhythmias? Or what is the concern in a patient, in a child presenting with arrhythmias? Yes, we are very concerned because the end stage or the final outcome of any arrhythmia is a progression to cardiac arrest. So if we see a child with arrhythmias, start anticipating that this child may develop cardiac arrest. And the cardiac arrest is a very poor outcome. But before a child progressing to cardiac arrest, the child will show the signs of being hemodynamically unstable. These signs include hypotension, signs of shock, altered mental status, and chest pain. The child develops these symptoms because the arrhythmia are so severe to an extent that the heart function is compromised, that the heart cannot maintain the normal blood pressure of the child, that the heart cannot maintain the perfusion of even the vital organs like the brain and the heart itself. That's why the child is developing ischemic chest pain because of myocardial ischemia or myocardial infarction. So these signs are danger signs. These signs are red flag. If you see this in any child with arrhythmia, start thinking or start anticipating that the child at any time will go to cardiac arrest. So there is one study which was done in the emergency department of Emory National Hospital by Dr. Emily and her colleagues looking on what predicts the cardiac arrest among pediatric patients presenting to the emergency medicine department. In this study, they found that independent predictors of cardiac arrest in these children were signs of shock, which was found during the primary assessment. And the second independent predictors was hypoxia. So if you see this, it means the child is hemodynamically unstable and is going to develop cardiac arrest at any time. And the cardiac arrest is a very poor outcome. There is another study which was done at the Muhimbili Emergency Department by Dr. Deogratas et al., who is a pediatrician working in a pediatric ICU. He was looking on what are the outcomes of children who are developing cardiac arrest at Muhimbili National Hospital in the emergency department. Dr. Deo, he found that in 3 years, 257 children developed cardiac arrest in the emergency department. Despite of the interventions they received, including cardiopulmonary resuscitation, including assisted ventilation, but 3/4 of these children died in the emergency department, while only 1/4, equivalent to 70 children, they survived in the emergency department until the time to be disposed to ICU. Even the ICU, the number of children who were dying keeps increasing. And in the first 24 hours after admission, 27 children died out of 70, those who were admitted to ICU. But it is very sad that at the time of hospital discharge, only 7 children survived, which is making a possibility of surviving after developing cardiac arrest is 2.5%. This means that if we see a child in the emergency department with the arrhythmia, make sure that that child does not progress to cardiac arrest. Otherwise, the chance of survival is 2 out of 100. So, pediatric arrhythmia or any arrhythmia is defined in 2 aspects. One is knowing the heart rate, knowing is it fast, is it slow. The second aspect is knowing the rhythm. The rhythm, we mean the way the impulse is generated and transmitted in the heart. In the normal child, the impulse starts in a sinoatrial node, and from there it goes to the all parts of the atrium and then goes to the AV node. From the AV node, it goes through the band of His, Purkinje fibers, and then all parts of the ventricle, which is followed by contraction of the ventricle. So this normal sequence of starting from ICA node to AV node to the ventricles is what we call a normal rhythm. But looking on the number of the heart rate or looking on the chest of the child will not help us to know if the rhythm is normal. We will not be able to know if the impulse is starting from the atrium, then going to the ventricle. So in order to know that, we need an special equipment which will look at the heart and inform us if the transmission or if the child has a normal rhythm or not. These equipment are cardiac monitors, defibrillator machine, and the 12-lead ECG. So if a child is connected to any of these equipment, they are going to look at the heart and they will draw the tracings or the graph on a ECG paper or on the screen of the cardiac monitor or the screen of a defibrillator. Those drawings or tracings or graph will be reflecting the way the impulse transmitted. So in a normal child, if the impulse is starting from the SCR node to the atrium, then the ECG machine or the cardiac monitor will draw a P wave, which we see here. And the P wave will be upward deflected or positively deflected. After that, the impulse will go to the ventricles, and the ventricle will become depolarized and then contracts. Then the ECG machine or the cardiac monitor of the defibrillator will draw the QRS complex. Before the heart starts another cycle, the heart has to go back to its original state. That means the heart has to become repolarized. So the ECG or the defibrillator or the cardiac monitor will draw a T wave, which is this one here. So a normal rhythm is the one which is a P wave followed by QRS, then followed by T wave. But this sequence is not enough to define a normal rhythm, but also we need to consider the time taken or the speed of transmitting the impulse from the atrium to the ventricle. So the time taken for the impulse to travel from SL node to the ventricle is represented by PR interval, which is here, from the start of the P wave to the start of R wave. So this interval indicates the time taken for impulse to travel from the atrium to the ventricle. And the maximum which is accepted in children is 0.2 second or 200 millisecond or 1 big box. In this graph, the y-axis is the voltage, where the x-axis is the time. So again, to define a normal rhythm, you need a specific time of transmitting the impulse within the ventricle. And this time normal is less than 0.09 second, or about 2 small boxes. So to know that if the impulse is transmitted at the normal rate or at the normal speed, we look at the base of the QR interval. If the QR interval base is within is 0.09 second, or is about 2 small boxes, then that impulse is normal. So the normal rhythm is the sequence that's starting with the P wave, then QRS, then T wave, and also the PR interval will be normal, meaning 0.2 maximum second, and the QRS will be narrow, meaning 0.09 second or less. So in the normal rhythm, we will see the rhythm like this on the bottom of this screen. You will start with the P wave, followed by QRS complex, then T wave. Then the PR interval will be normal, meaning with less than 1 big box, and the QRS will be narrow, meaning will be less than 0.09 second. So what are the classification of pediatric arrhythmias? So the American Heart Association has classified pediatric arrhythmia into 2 main groups. One is pediatric arrhythmia, which presents with bradycardia, and we call those arrhythmia as blood arrhythmias. The second group is pediatric arrhythmia, which presents with tachycardia, and we call those arrhythmia as tachyarrhythmias. Let's start with blood arrhythmias. Unfortunately, in pediatrics or in children, we don't have a one cutoff of heart rate which defines bradycardia or tachycardia. So each age group will have its own cutoff heart rate for bradycardia and tachycardia. So before you diagnose the child that have bradycardia, you need to know what is the normal heart rate of this child at this age. Because a heart rate of 70 may be normal in an infant, but it is an arrhythmia in another, it is bradycardia in another group. So make sure that at even age group, you know what is the normal heart rate for that child, what is the normal, how is it defined bradycardia, how we define tachycardia in that age group. But not only about the number of the heart rate, but also even the QRS complex, PR interval, the morphology of the P wave, of the QRS, of the T wave, it varies from age to age. So before saying that this is arrhythmia, this rhythm is abnormal, you need to know what is normal at that age in terms of the PR interval, the width of the QRS, and the others. There is one study which was done in Egypt looking on the pediatric patients who are presenting with bradycardia in the emergency department, pediatric ICU, and arrhythmia clinic. They found that the most common bradyarrhythmia in those children was sinus bradycardia, which accounted 70.5%, followed by complete heart block, then first and the second degree heart block. So in other words, the most common arrhythmia, bradyarrhythmia in children is sinus bradycardia, heart block, complete heart block, first degree heart block, and the second degree heart block. And these are the arrhythmias we're going to discuss in this presentation. Let's start with sinus bradycardia. In sinus bradycardia, the problem that the sinoatrial node is discharging the impulse at a very slow rate according to that age of the child. So the rhythm, meaning the sequence of where the impulse starts, where it goes next, and where it ends, it is the same. That means if you look on ECG, you have a normal P wave, which is followed by a normal QRS, which is followed by T wave. So the PR interval will be normal, the QRS will be narrow. The problem that the heart rate is very low, is low. Even if the cardiac monitor, you will see normal P wave, normal QRS, now SA node is discharging the impulse very slow. So is the sinus bradycardia a problem? Yes, it is a concern. Remember, a child depends very much on the heart rate to maintain the normal blood pressure, to maintain the perfusion of the vital organ. So if the heart rate keeps decreasing and decreasing, it will reach a time the child will not be able to maintain the normal blood pressure and the perfusion. As a result, the child will become more dynamic and unstable, and then will progress to cardiac arrest. The second type of bradyarrhythmia is AV block first degree. In first degree AV block, the problem that the impulse in the AV node is slowed down. It will be allowed to pass, but will be delayed there. So in that, the impulse in the first beat, if it is delayed for 1 minute, for 1 second, or 1 millisecond, even in the second beat will be delayed for 1 millisecond. In the third beat will be delayed on this same duration. So as a result, the rhythm would be regular, meaning the interval from one beat to the other will be the same and they will be regular. If you look on this ECG, this is a P wave, this is the start of R wave. So the PR interval normal is less than 1 big box. Here, it is more than 1 big box. If we check the second beat, it's also more than 1 big box. In the third beat, it is more than 1 big box. So the PR interval is prolonged and it is uniform. This kind of rhythm, it is AV first degree block. And that child has blood arrhythmia. The third type of blood arrhythmia is AV block second degree. Second degree AV block has two types, type 1 and type 2. Type 1, that the impulse from SA node is progressively slowed down, As a result, it will keep delayed, and it will reach a time the heartbeat will be dropped. Reach a time the impulse will not be allowed. So in type 1, there is a progressive prolongation of PR interval. If you look at this ECG, the PR interval, yes, it is more than 1 big box, which is prolonged. If you see on the second beat, it is more prolonged, more than the first beat. In the third beat, it is also more and more prolonged than the second and the first. So the sequence will go like this until when there is a drop of the beat. As you can see here, there is a P wave, but there is no QRS. That means the impulse was generated in the senator node, but on reaching the AV node was prevented from passing to the ventricle. As a result, there is only atrium contraction, but without ventricular contraction. This kind is called type 2, is called type 1 of second degree heart block. In type 2 of the second degree heart block, the SA node will allow some of the impulse to pass normally, and the other impulse will not be allowed to pass. There will be no prolongation of the PR interval, but the SA node will allow either 2 beats normal, then the third beat will be blocked, will allow another 3 beats, then the fourth will be dropped. It goes like that. As you can see in this ECG strip, we have P wave, QRS. In this, PR interval is normal, QRS is narrow. There is another P, QRS, normal QRS, normal PR interval. In the third, there is a P wave, there is a QRS. Again, PR interval normal, QRS narrow, T wave normal. But on the fourth beat, there is only P wave without the QRS. That means here, the beat or the impulse was blocked complete, and that's why we don't see ventricular contractions. So the sequence will continue like that, and the rhythm will be irregular. The last type of blood arrhythmia is complete heart block or third-degree heart block. In this kind of arrhythmia, there is complete blockage of the AV node. There is no impulse from the atrium, which is passing to the ventricle. As a result, the atrium will contract on its own or will be depolarized on its own, and the ventricle will be depolarized or contracting on its own. So there is no relationship of P wave and the QRS. Remember, in normal sinus, we start with the P wave, then followed by QRS, meaning we start with atrium depolarization, then ventricular depolarization. So there is a relationship that in every P wave, you have a QRS. In every P wave, you have a QRS. But in third-degree heart block, there is no relationship. The atrium is beating on its own, and the ventricle is on its own, like in the one we see in this screen. Then the second type of pediatric arrhythmia is tachyarrhythmias. In the tachyarrhythmia, the problem that the heart rate is higher than the normal for that age. So in the tachyarrhythmia, you can have a rapid heart rate plus abnormal rhythm. That meaning the sequence is also not followed, like the sequence of starting from SER node to the ventricles. So you can have both rapid heart rate but normal rhythm, that the sequence is not followed. The impulse in tachyarrhythmias can start from atrium or can start from the ventricle. So as a result, we have tachyarrhythmias with narrow QRS, and we have tachyarrhythmia with wide QRS. So what is the difference between tachyarrhythmias and blood arrhythmias? In blood arrhythmia, because the heart rate is high, the children can tolerate that, because in a normal child depends on increasing the heart rate to maintain the normal blood pressure. So the child with tachyarrhythmia can tolerate that. As a result, they present to the hospital late rather than those with bradycardia. Those bradycardia, they will go to hypotension very fast, will have signs of shock very fast compared to those with tachyarrhythmia. But if tachyarrhythmia continues, that the heart rate keeps increasing, it will reach a time that there is no time to refill the heart. There is no time for venous return. As a result, the blood pressure will drop, and the child will develop sign of instability, and the child will develop cardiac arrest. Then in the tachyarrhythmias, we have also some classification. We have subtypes. Type 1 is the tachyarrhythmia with a narrow QRS. Narrow QRS, it means it is less than, the width is less than 0.09 second, or it is about 2 small box. Example of tachyarrhythmia with narrow QRS include sinus tachycardia, supraventricular tachycardia, and atrial fibrillation. The second group of tachyarrhythmia is the tachyarrhythmia with wide QRS. Wide QRS means it is more than 0.09 second or more than 2 small box. Example of these arrhythmias: ventricular tachycardia, ventricular fibrillation, or supraventricular tachycardia with aberrance. Unfortunately, ventricular fibrillation occur in a child with cardiac arrest, will not occur in a child with a pulse, so will not be discussed in detail in this presentation. Then let's start seeing different types of tachyarrhythmia. The first example is sinus tachycardia. In sinus tachycardia, the heart is beating very fast. So the SA node is initiating the impulse, but very fast. As a result, the heart rate goes up. How do you recognize the sinus tachycardia? First of all, it occurs as a normal physiological response. If the child is stressed, if the child is hypoxic, if the child has hypovolemia, they will start showing the signs of tachycardia. So any stress will cause that to go up. So on the ECG, the rhythm will appear normal in the meaning of the sequence that will start with the P wave, then QRS, and the QRS will be narrow. And we will have P wave and the T wave. As you can see in this rhythm, cardiac monitor, we can see the P wave and the T wave. In the normal ECG again, we see a normal P wave and a T wave. This is sinus tachycardia. There is narrow QRS, there is a P wave followed by QRS, then followed by T wave. Response. The second type of tachyarrhythmia is supraventricular tachycardia. In supraventricular tachycardia, it means the impulse is originating above the ventricles, but to be more correct, is above the band of His. So there are two mechanisms of developing supraventricular tachycardia. One is that the impulse which is generated from a SA node, it goes to the ventricle, but it finds a way. Some of the impulse finds accessory pathway and goes back to the atria and stimulates the atrium. So as a result, you have increased speed of generating or depolarizing the atrium and then the ventricles. Another mechanism of developing supraventricular tachycardia is that some of the impulse which was generated from the SA node will find another accessory pathway and go back into the AV node and stimulate the AV node. As a result, we have two types of supraventricular tachycardia. One is atrioventricular reentrant tachycardia, or atrioventricular nodal reentrant tachycardia. Nodal, it means the accessory pathway is within the AV node. In ventricular reentrant tachycardia, the accessory pathway is from the ventricle going back to the atrium. This is an example of supraventricular tachycardia. As you can see, you may confuse it with sinus tachycardia. But if you look closely here, you cannot differentiate between the P wave and the T wave. P wave and the T wave are occurring together because the heart rate is so fast. So the machine or the ECG cannot differentiate the P wave and the T wave. So if you see the rhythm like this is a supraventricular tachycardia. It is narrow, QRS, there is no P wave. Another type, usually the CVT is narrow, but it may happen sometimes you have SVT with a wide QRS. This happens when two or more arrhythmias are occurring together. For example, the patient has SVT, but on top of that has first-degree heart block. So the QRS will appear wider than the normal because of the presence of heart block, which makes the transmission slow. The literature says, if you cannot differentiate SVT with ventricular tachycardia in a child, it is better to treat this kind of rhythm as a ventricular tachycardia. Don't assume it is SVT unless you have a previous ECG or you previously know that this child had existing heart block or has existing WPW. If you cannot differentiate, treat as ventricular tachycardia. Another type of tachyarrhythmia is called atrial flutter. In atrial flutter, the problem that we have multiple points in the atrium which is generating the impulse. As a result, we have multiple P wave, but with few QRS complex, meaning we have more atrial contraction than ventricular contraction. As a result, you can see like in this ECG, there is multiple P wave where we have few QRS, multiple P wave, few QRS. This is called atrial flutter. More P wave than QRS. Where in normal one, we have normal P wave, one QRS. One P wave, one QRS. But if we have multiple P wave with one QRS, that is atrial flutter. The last type of tachyarrhythmia is ventricular tachycardia. In this case, the problem that the ventricles are the one which have generating the impulse and not the cell node. And at this time, the ventricle is beating very fast, is depolarizing very fast, and the ECG or the cardiac monitor will show a wide QRS. Any rhythm which is started in the ventricles will appear wide. Any impulse started in atrium will appear narrow, unless otherwise there is aberrance. So this is a rhythm of ventricular tachycardia. So in summary, if you have a child presenting in the emergency department with arrhythmias, number one, identify and treat any secondary causes like hypoxia, hypovolemia, acidosis, hypokalemia. So make sure you fix those secondary causes. Then after, decide or reassess the child and see, is this child hemodynamically stable or unstable? Because if the child is unstable, it means the child is heading to cardiac arrest. You need to be more aggressive. Then after, you need to decide, is this rhythm a slow or fast? Is it a tachyarrhythmia or bradyarrhythmia? Because the algorithm of treating bradyarrhythmia and tachyarrhythmia, they are different. And then knows what rhythm is this. Yes, it is bradyarrhythmia, but which rhythm? Is it first degree at block, second degree at block, or complete at block? If it's tachyarrhythmia, what rhythm is this? Is it SVT, or is it ventricular tachycardia? Is it atrial flutter? Then from there, we will be able to initiate the treatment accordingly. And this is the end of my part. Thank you for listening.
Hello, everyone. Thank you, Dr. Biita, for that awesome overview of pediatric arrhythmias. I'm very happy to be with you today and take over the second part here. Can everyone see my screen okay?
Yes, we can see it.
Thank you. So I'll continue on talking more about the treatment for pediatric arrhythmias, as Dr. Biita has just helped us understand the types that we might be looking for. I'll just review this approach because I think this is a really important place to start when you are considering an arrhythmia. Of course, we always start with ABC and trying to figure out if this child is stable or unstable. And then you can just classify the arrhythmia as fast or slow. Think about the etiology of secondary arrhythmias, which we've covered and reviewed here. And then it will help you diagnose the rhythm and be able to treat it appropriately. So we have a few patient cases in this section, which will hopefully help demonstrate this approach and help you feel more confident in diagnosing and treating pediatric arrhythmias. This is our first patient example. So you receive a 2-year-old who's transferred, who's had respiratory distress. They have been sick for a few days with this. When you see them, the airway is clear, but they look very hypoxic and cyanotic. Their perfusion is poor, the pulses are weak. And as you're evaluating them, they become bradycardic and you see the heart rate as 45. So in this scenario, just think to yourself, what do you do next? What might be the cause of this arrhythmia? And if we go back to our approach, we can think about this patient and start with ABC. This is an unstable patient. Of course, they're in shock. They have poor perfusion. They are cyanotic. And this is a slow rhythm. So we think right away about the secondary arrhythmia causes. And this child is very hypoxic, leading likely to this sinus bradycardia and peri-arrest state. So we can quickly diagnose the rhythm, even just from the cardiac monitor, and see this is probably sinus bradycardia. This child will progress very quickly to asystole. And so the correct treatment in this scenario is you're going to start CPR right away as they have such a slow rhythm and a poor perfusion and pulses. And most important to correct would be the hypoxia. So you're going to provide bag mask ventilation with 100% oxygen and hopefully be able to resuscitate this child and increase the heart rate. So another case of bradycardia, but a little bit different this time. Now you have a 12-year-old who comes in, who's a CP patient, who's malnourished. This child had a seizure and received diazepam once and stopped seizing, but is now post-ictal and sleeping. The heart rate drops to 55. You assess this child, the airway is clear, they are breathing normally, the lungs are clear, they have strong pulses, you have normal capillary refill, and a normal blood pressure for their age with a normal saturation on room air. So for this child, you're thinking this is bradycardia. What do I do next? And what are the risk factors for a secondary arrhythmia in this patient? So back to our approach, starting with ABC, this child is stable. This is a slow rhythm. And what are some of the secondary arrhythmia causes? So for this child, they're malnourished, which could cause a slower heart rate and cause sinus bradycardia. They also just received diazepam, and so that also would cause bradycardia. It would be ideal to try and get a 12-lead ECG in this scenario so that you could be sure there were no other primary causes of arrhythmia and confirm your suspicion that this is a sinus bradycardia. But for this child, you're going to monitor very closely. You might put them on oxygen. You might make sure that they're euvolemic and they have normal hydration status and monitor their perfusion closely. And you would expect that heart rate to improve as the drugs wear off and as they wake up a bit more. So two very different cases of sinus bradycardia in terms of your treatment. And when you do get the 12-lead ECG for that child, here it is. So you have a normal axis, you have a sinus rhythm, you have a slow rate. Here's a reminder of the pediatric advanced life support approach to sinus bradycardia, or to bradycardia, excuse me. So you might be familiar with this, but just to review, as you're going through this algorithm, for both of these cases, we had a child presenting with bradycardia. The first step is that stable versus unstable. That'll change everything in how you manage this child. So you want to know, is their cardiopulmonary compromised? Are they altered? Do they have signs of shock? Are they hypotensive? If the answer to those is no, you're going to support the ABCs, meaning you're going to continue close monitoring. You're going to provide oxygen, observe, try to get the 12-lead ECG and figure out and treat any underlying causes. But if the answer to the cardiopulmonary compromise is yes, now you need to act more quickly. You're going to maintain their airway. Likely, you're going to be assisting with breathing and positive pressure ventilation, oxygen as necessary, and you're going to be monitoring the rhythm on your cardiac monitor, the blood pressure and the perfusion and pulses very closely. If we continue down this algorithm after that initial branch point, below the box where you're supporting ABCs and there is cardiopulmonary compromise, the heart rate cutoff to begin CPR or to consider beginning CPR in children is 60. And of course, we just discussed a case where the heart rate was lower than 60, but CPR was not indicated because they had good perfusion and normal oxygenation. But for children who are unstable and have a heart rate under 60, that is the cutoff to begin CPR. And then you're going to be thinking about IV access and using epinephrine and atropine to assist you with resuscitation while you're doing CPR. And the doses there are on the right. And while you're doing this, you're going to be thinking about your underlying causes: hypoxia, medications, electrolyte imbalances, or hypothermia. And just to review, Dr. Biita mentioned some of these as well. As you're thinking about sinus bradycardia, I put hypoxia in all caps because that is the most common reason that children would be progressing to sinus bradycardia, and asystole would be a respiratory arrest. And so that is really a very important thing to consider and to correct. You also have acidosis, hypotension, so septic shock, if they're in severe septic shock for a prolonged period of time and hypotensive, they will also progress to having sinus bradycardia before they arrest. And then hypothermia, drug side effects. Increased vagal tone is one reason that you could have an intermittent bradycardia that would then resolve after the vagal tone improved. So if you have a child who's actively vomiting or who you're doing suctioning, you might briefly see the heart rate decrease, but then it should recover and come back up. And then the primary causes of sinus bradycardia are going to be less common. So the abnormal conduction that Dr. Biita reviewed, or cardiomyopathy, or myocarditis. All right, moving on now to a new example. And now we're in a fast heart rate state. So we're into tachyarrhythmias now. This is a 6-week-old boy brought to the emergency department for fast breathing and poor feeding. He was previously healthy and a term child and has had 2 to 3 days of fast breathing and poor feeding. When you check him into the EMD and you get some vital signs, you see he has a very fast heart rate of 220. His respiratory rate is only 14, so very slow. His blood pressure is 58/30, and his saturation is 88%. And he's a well-nourished baby with a weight of 4.3 kilos. So he has been well up until this acute event over the past couple of days. So this is a sick child who you're going to immediately think about your ABCs. The airway is clear. The breathing is non-labored, but a decreased respiratory rate. The lungs sound clear. The circulation is poor. So you have mottled extremities, which are cool. You have cyanosis, the tachycardia, and a weak pulse. On D, there's a weak cry. You have moving all extremities, so not a focal exam, but the GCS is diminished at 12. And on exposure, they're normothermic. There's no evidence of trauma. The fontanelle is flat. So maybe just think to yourself for a minute in your approach. First question is stable or unstable. This is an unstable child, and we have a problem with circulation and hypoxia. So we definitely, and as we complete the ABCs, would determine this child is unstable. The blood pressure is also low, so they're hypotensive, which we know in children is always an emergency. They don't tolerate being hypotensive for long, and they don't become hypotensive until they are very, very sick. This is a fast heart rate now, so we're thinking about the tachyarrhythmias. So we think about the etiology of secondary arrhythmias. Could this be sinus tachycardia? And we'll talk about some ways to try and differentiate sinus tachycardia versus a supraventricular tachycardia next, because that will help us diagnose the rhythm and be able to treat it appropriately. So if you're able to get an ECG on this child, it can be very difficult in small babies. This is the ECG that you get. And in the interest of time, I'll keep moving on here rather than pausing, but everyone can just take a look and think, what would I be thinking if this were my patient? We see a very fast, narrow, complex tachycardia, very regular, and we don't see the presence of clear P waves before every QRS. So this is an example of a supraventricular tachycardia, reentrant tachycardia, which Dr. Biita taught us about. And here are some considerations, because in real life, this can be very difficult to differentiate in a sick neonate, especially. Is this SVT and I need electrical cardioversion, or I need adenosine, or is this sinus tachycardia? So here are some ways that you might be able to differentiate. There are several features that will help you. First, with the history. In sinus tachycardia, you have a baby who's been having fever or dehydration, is screaming in pain, and those are some things which might cause a sinus tachycardia. Whereas a supraventricular tachycardia, you have a well baby who had an abrupt onset of, an abnormality. In babies, it can still be a bit vague, but this should be more of an abrupt onset, maybe no fever, for example, in this baby. The rate can also help you. So these cutoffs are not exact, like 221 is definitely supraventricular tachycardia and 219 is definitely sinus tachycardia, but they're just a general guide. If the rate is above 220 in infants, it is likely that that is an abnormal rhythm. It is difficult to get a sinus tachycardia much above 220 in an infant. And then for older kids, we use 180. So it means if you see a rate of 240 that's very regular on the monitor, you should be thinking that there's a high likelihood this is a supraventricular tachycardia. I once had a baby present with a rate of 315. There's no way that that is going to be a sinus tachycardia. So think about that cutoff, not as an exact threshold, but just as a general guide to the likelihood of this being a supraventricular tachycardia versus a sinus. And then the variability is important as well. So for children with a sinus tachycardia, they will cry, the heart rate will go up, they will calm down, it will come back down, they'll be able to feed, it will come back down. So you'll see that it goes up, it goes down. You don't see a lot of, you see the variability. And with an abnormal rhythm, a supraventricular reentrant tachycardia, it's completely fixed. There's no variation because you have that reentrant cycle and there's no variability at all according to the state of the child. The P waves, of course, we discussed. You should see normal P waves and a normal axis in a sinus tachycardia. And in the SVT, they'll be absent, they'll be buried or retrograde as part of the T wave. And finally, the response. So if you have a sinus tachycardia, you give some fluids, you bring a fever down, you will see it improve. And SVT will not change. You will need to use vagal stimulation, medications, or cardioversion. The SVT can present in two different ways in pediatrics. In babies, it can be quite vague and subtle and nonspecific. So this child, this case I've given you, presented with poor feeding and fast breathing. And this is often the case because there's not a lot of specific symptoms. They can tolerate this high heart rate for quite a while. So when they show up, they might actually be in cardiogenic shock and in heart failure. About 50% will present that way because it's difficult to recognize. In older kids, they tend to feel the onset of SVT. So they will tell you they feel palpitations, they feel chest pain, they feel dizzy, dyspnea, and this will be an abrupt onset. They can have syncope as well. It's a bit more rare, but it is a concerning symptom since it means they're having poor cardiac output with the abnormal rhythm. So if you see a baby who you think might be septic, but never had a fever and has this very high heart rate, think about SVT. In the acute management algorithm, and I'll review the pediatric advanced life support algorithms in a bit here as well. Again, the first question with SVT is stability. Are they stable or unstable? Are they hypotensive? Do they have altered mental status? Are they in shock? Are they in heart failure? And that will tell you which treatments you need to reach for first. So in the example I gave you, remember this is a 6-week-old baby who was hypotensive, hypoxic, poor perfusion, weak pulses. So we know this baby is going to be on the red side, unstable side. And we're going to proceed with synchronized cardioversion as quickly as possible. And we're not going to delay looking for medications. The dose for synchronized cardioversion is 0.5 to 1 joules per kilo. So it's a lower dose than for defibrillation. If the child were stable, if the heart rate were, or if the blood pressure were okay and the perfusion were okay, then we can start to think about vagal maneuvers. So ice to the face or a Valsalva in older kids. We can look for our adenosine and start that at 0.1 mg per kilo. And we can think about second line medications if the adenosine does not work. Here's an example of the vagal maneuvers. So if you do have a stable child in SVT and you're thinking about converting them using vagal maneuvers, for infants, the diving reflex is what we are looking to provide here with a vagal stimulation. There's an example there of how you might place the ice over the forehead, eyes, and nose and hold it there for 15 to 20 seconds. This will cause an intense increase in the vagal tone, which should slow AV node conduction and help reset that reentrant tachycardia beat. For children and adolescents, you can have them take a syringe that is closed on the end and blow as hard as they can, and you'll have to encourage them to blow hard, hard, hard into the syringe and try to move the plunger themselves for 15 seconds while lying supine, and then take their legs and raise them passively up at about 90 degrees. You can repeat this cycle a few times and see if you can increase the vagal tone enough to get that AV node slowed, the conduction slowed, and reset the reentrant tachycardia. There are other options like carotid massage or orbital pressure, but there have been bad outcomes with this over time, in which the carotid artery is obstructed or there's orbital injury. So these are less preferred in children when you're thinking about vagal maneuvers. While you're doing this, it's probably a good idea to if you can find adenosine, get it ready, because these are not always successful, even though in a stable patient, they're definitely worth trying. And if you're progressing to synchronized cardioversion because you have an unstable patient, this is just a reminder of how you would proceed with that. So you have your anterior and posterior pads or paddles across the heart. You have, and actually I'm noticing this picture, I would like that upper anterior to be a bit farther on the right side of the patient to be optimally positioned. You're going to use 0.5 to 1 joules per kilo. Very, very important that you synchronize this delivery of electrical activity. So if it's unsynchronized, you can put the child into asystole or PEA or ventricular fibrillation. And so it's very, very important that this be a synchronized cardioversion, meaning that the electricity will be delivered on the QRS complex and not randomly throughout the cardiac phase. If they're stable enough to consider sedation, that's a nice thing to consider. It's an uncomfortable procedure, and so you can consider using ketamine or midazolam if time permits. But if they're very hypotensive with altered mental status, it's better to proceed and not delay. And then adenosine is a chemical cardioversion, if you have access to it, that can work very well for SVT. And adenosine, a few things that are important about it. It has a very short half-life. So when you're giving adenosine, you need to be flushing it very quickly, ideally with the 3-way stopcock shown here, and ideally with an IV that is as close to the heart as possible. So an antecubital IV, as opposed to an IV in the foot, if possible. As you give the adenosine, you're going to push and flush as quickly as possible so that you can get it to the heart. You block the AV node. So if you're able to watch on the cardiac monitor, you would see this pause and then resuming the normal P wave and normal sinus rhythm afterwards. The initial dose would be 0.1 mg per kilo. And then if that doesn't work, you can increase to 0.2. Sometimes adenosine fails, or you see it resumes the sinus rhythm and then goes back into SVT. So then you can be thinking, what happened? Was it technical failure? Did I push it too slow, or was the IV too far from the heart? Was the dose too low? And try increasing the dose. And you can try a few times to use adenosine. It's okay to give a few doses and see if you can be successful. If you had the wrong diagnosis, let's say that this was actually an atrial flutter with ventricular conduction, and you had a very fast rate, you couldn't see the atrial flutter, you couldn't see the P waves that were there. When you have a pause in the AV node conduction, you'll see the atrial flutter at the baseline. So make sure that you're watching your cardiac monitors when you give adenosine, because it will unmask potentially another type of arrhythmia if it's not SVT. And here are some other medications that are used in refractory SVT. So when the adenosine is not working, but you have a stable patient and you want to try other medications before you progress to a synchronized cardioversion, you can use procainamide, amiodarone, or esmolol. And if you don't have adenosine, or you don't have any of these medications available, it's also reasonable to try an IV beta blocker. Just a quick note about one underlying cause of SVT that some children will have, a syndrome called Wolff-Parkinson-White, WPW. This is the presence of an accessory pathway that can predispose people to going into SVT. So children who have this will often have a history of having multiple episodes of SVT. Sometimes they even can convert themselves using a vagal maneuver because they've learned that bearing down, holding their breath might change their sensation of the palpitations. They can actually treat themselves. If you were able to get an ECG when they are not in SVT, this is what you would see is the delta wave or a slowed upstroke of the QRS complex and a short PR interval and a bit wide QRS. And if you can diagnose this, most children will stay on oral beta blockers to try to prevent SVT. And if you know a child has this, you want to avoid digoxin or verapamil because it can actually facilitate a one-to-one conduction of AFib and put them into ventricular fibrillation. That's just an important thing to know about. Okay, I'm nearing the end here, but I wanted to say a few things about wide complex, the treatment of a wide complex or ventricular tachycardia. These are going to be much more rare in pediatrics, so we didn't want to emphasize them too much, but just so you should know the approach when you might see this on a monitor. So this is an example of a fast rate, which is wide complex and monomorphic, which means all the shapes of those QRS complexes are the same. They look about the same. They look symmetric, the same width, the same height. And in a ventricular tachycardia, you would expect that rate to be at least 120, so maybe not as fast as the SVT. The QRS is wide but regular. You will not be able to see P waves most often. You will not be able to see them because this is a ventricular source of the rate. And if you can see T waves, they'll often be opposite to the QRS. If you see this rhythm and the child does not have a pulse, this is an immediate indication for defibrillation. And of course, you will be doing CPR. If they have pulses and are stable, which sometimes will happen, then you consider a pharmacologic conversion. And I have the drugs for you on an upcoming slide. The reasons this might happen in a patient may be an underlying heart disease, maybe a rheumatic heart disease, or maybe they've had cardiac surgery. Maybe they have a long QT syndrome, a genetic syndrome, which gives them a prolonged QT. This is going to be rare, but of course can happen. Maybe they have a cardiomyopathy or myocarditis, and so they have an inflamed and stretched myocardium that has abnormal conduction. Or you can see it with extreme severe hyperkalemia, hypocalcemia, or hypomagnesemia. This rhythm is also a ventricular tachycardia, but this one is polymorphic. The shapes are changing, right? You have high amplitude and then low amplitude, high amplitude and then low amplitude. And they're all wide and look abnormal. This is also a fast rate of 120 to 150, but you have this rotating amplitude of the QRS complex. This is often not a perfusing rhythm. So if you feel a pulse, you are likely to lose that pulse. Rarely you can have a pulse with this rhythm. Right when you see this, the first thing you should be thinking medication-wise is magnesium because it can stabilize the cardiac membrane and potentially treat this rhythm and bring it back to a sinus rhythm. So the magnesium dose you would be thinking would be 25 to 50 milligrams per kilo in an IV slow push. If they're pulseless, this is a rhythm you would provide defibrillation, and of course you would be doing CPR. Reasons that you might have this rhythm may also be these long QT syndromes. Again, these are going to be rare, but they're often congenital and inherited. You might have hypomagnesemia or hypokalemia. So remember, hyperkalemia predisposed you to the monomorphic rhythm, whereas hypokalemia can predispose you to this one. This can be a toxicity from an antiarrhythmic drug, or there's several other potential toxicities that can cause this. Tricyclic antidepressants, calcium channel blockers, or phenothiazines. Almost done here. Just a quick review of the Pediatric Advanced Life Support approach to tachycardias. So at the top, again, we're first assessing stable or unstable. If possible, we're putting them on, getting a 12-lead ECG, but if not, we're at least going to get them on a monitor to try to determine the rhythm. And if there is cardiopulmonary compromise, they're altered, they have signs of shock or hypotension, we're going to be following the left side of this algorithm. If not, we'll be following the right. And this is the zoom in of the second step here. So remember on the left, we have the unstable patient, and we're looking at the duration of the QRS complex. If it is narrow, we'll be thinking probably of an SVT, a supraventricular tachycardia, and it reminds us there of the ways we might confirm that, the features that would be most consistent with it. If we already have IV access, we can give adenosine quickly. If not, we're going straight to synchronized cardioversion and we're not going to delay. We have an unstable patient with a narrow complex tachycardia. If the QRS duration is wide, then we're thinking this is a ventricular tachycardia. And again, we're providing synchronized cardioversion. And anytime you have a pulse and you're providing an electrical shock, this should be a synchronized cardioversion. It has to be given when the QRS complex goes. Now, on the right side, we have, oops, it's hard to go back with this. There we go. On the right side now, remember we have no cardiopulmonary compromise. So this is a stable patient who has a fast tachyarrhythmia. We're still going to figure out, is this narrow or wide? If it's narrow, we're still thinking this is probably a stable SVT. Now we think about our vagal maneuvers and we think about adenosine. If they have a wide complex and they have a stable tachyarrhythmia, now we try to tell if this is regular or monomorphic or polymorphic. If it's a regular monomorphic, even if it's wide, if it's fast, you can still think about adenosine because sometimes that reentrant, the AV node reentry is farther down toward the ventricle and you have a wider complex and it's still an SVT type mechanism. So it's reasonable to consider adenosine if it's a regular monomorphic tachyarrhythmia. If it's polymorphic, you should never give adenosine. And then the medications you might also consider for a stable ventricular tachycardia, they're there at the bottom. So amiodarone and procainamide can also be given. And just as a last reminder, if you have a patient with no pulse who has the one of these rhythms, a ventricular tachycardia, or on the bottom, a ventricular fibrillation, you should be providing a shock defibrillation at 2 joules per kilo as quickly as possible while providing CPR. And we've come to the end, a bit over, sorry about that, but here's a summary of what we've covered today. We defined pediatric arrhythmias, the outcomes, the approach. We went through sinus bradycardia, sinus tachycardia, and SVT, and some wide complex tachyarrhythmias. And we'll be happy to take any questions. Thank you so much for your attention. And if you're able to fill out evaluation, we would really appreciate it.
Okay, thank you very much, Dr. Biita and Dr. Emily, for a very nice presentation, clearly explained and elaborated. I know it's one among the topics that keeps confusing, but thank you very much for taking us through in a way that is easy understood, and we hope our participants have learned a lot. So if there'll be any questions, I know it's 5 minutes past our normal time, but we can still allow 1 or 2 questions. You can either unmute and speak, or you can just put it on the chat and we'll see it. But as well, just as a reminder for those that are joining late, this is a CPD accredited activity. You can put your name and MCT number on the chat and we'll help you claim the CPD. But just to note, as of now, the MCT portal is being updated, which I'm sure majority of you would have seen that. So there are challenges a bit on how to access it and claim the CPD, but they're working on it. We'll have the reports the moment it starts working again. We'll make sure that we claim all the CPDs that you are supposed to receive. So rest assured, once the MCT portal is working, you all get your CPDs. But also, again, this lecture series happen every month, and we always record them and we put them in our YouTube channel for someone that missed or will want to go and listen to them again. You can always listen them on the YouTube channel that I've shared the link on the chat. And I know there are a lot of interesting topics that one would like to learn. You can just fill in the survey that I've also sent. any topic that you want us to talk about, and we'll put that into consideration. Okay, seems to be no questions from the participants. So I'd like again to say thank you very much for all that have joined in today, and I hope your evening has been very productive. I'd like to also say thank you to our presenters, Dr. Emily and Dr. Biita. And this marks the end of our today's presentation. We'll just leave the chat open in the next 2 minutes, after which we'll close the chat and the meeting. I'd like to wish everyone a good evening and a good morning to our colleagues. But also remember, there is a link that has been sent for an evaluation. Feel free to fill it just as a follow-up.